thesis by Prashant. A great day today for him as for us. I think it was a good process, many discussions and so on. I'm the chairman of the jury, and the members of the jury are Professor Jean-Mac and Professor Barthiel as promoters, Professor Urtik as the external member of the jury, and Professor Kegels. Professor Devadasan, I think he's not present.
It's on Skype.
Does it work or not?
I think so, yeah. I think somebody
could be
is
the surprise of the day. Well, I have a question. He gave me a question, so only 3 questions, don't worry.
Okay.
And I can pick the one I would like. So I will let Jean or Bart introducing.
Yes. So good evening, everybody. Thank you very much. But something before introduction, I want to do as to put down the screen. On the right, on your right. No, up. No.
The button is the first step.
So, I think the way Prashant is behaving is how I know Prashant is not only a medical doctor, he's not only, and I think most of you know him better than me, he's not only a faculty from the Institute of Public Health of Bangalore, but I think he's a person with many different roles and functions, and I do not know many of his functions. So, just before it started, I just want to be sure that I have a chance to already thank him for all the very good things he done to me in this process. I would like also to thank an academic party for coming especially for this event. And if Deva is somewhere in the cloud, just to say him hello. So Deva was, I think, also a very strong supporter of the thesis of Prashant, helping him a lot when being in India. I think the floor is to you, Prashant.
Two, 1, 0. Yeah. It's a lot of Hi.
Thank you very much, Professor William Dore, and thank you very much, Jean-Marc, for the introduction. And thank you very much to all the members of my jury, Professor Hertig, Professor D. Kegels, and Professor Barthiel. for this opportunity to finally defend my PhD dissertation, which is titled Capacity Building and Performance in Local Health Systems. It's a realist evaluation of a local health system strengthening intervention in Tumkur district of India. Over the next 20 to 30 minutes, I hope to explain what this title is and what I did over the last few years. The scheme of the presentation is going to be somewhat like this. First, I will discuss with you what it is to be a health manager at a district or sub-district level in India. Being a health manager is basically the most central subject of my dissertation. So, then we will discuss a bit on getting from capacity to perform to actual performance. What is that journey like from having the capacity to perform to actually realizing that capacity? With that background, I will share my research questions, how they evolved over time, the methods, and how these methods also evolved in course of time, and finally, of course, the results, the lessons learned, and limitations. To begin with, the central subject of my dissertation was health managers. Health managers are really at the center of several things. On one hand, you have a variety of policies and programs which are being designed to improve healthcare and health services of the community. And on the other hand is the demand of the people who demand that services ought to be of better quality, they ought to be of a certain kind. And the manager of health services in most lower and middle income countries, perhaps elsewhere also, is central to realization of these top-down policy program pressures and the bottom-up pressures of and demands of the people. Together, the manager is also in the middle, in the district, in interface with various other district services. There's education, there's social welfare. So if you look at a manager, he is quite central to realizing this dream of better health status and better health care at the district and sub-district level. You can look at the health managers as being somewhere at the meso level. So he's neither the person who is writing the policies or framing these health policies, nor is he the actual implementer. He's also not the person who is delivering, providing health services. He is the person who is coordinating and managing and ensuring that these things happen. And if you say, being a health manager in a country like India, where this map, I don't anticipate for you to get into the details of these maps, but to rather look at the disparity. This map shows actually the child mortality in various, in the 600 odd districts of the country. So India is a large country, and the number of districts is nearly around 600 districts. And child mortality is but one indicator. With respect to various indicators across the country, we see a difference. So these are due to many things. One cannot assume that the districts doing poorly is because they are poorly managed, and the districts doing better is because they are well managed. Because a lot of social determinants, poverty, income inequalities, and various other contextual factors matter when we talk of health indicators. But if you go to Karnataka, this is the district where in South India, where most of my work was based, you see again this disparity in health indicators. In this map, which is a map of talukas, in India talukas are sub-districts, and talukas are quite large. They already have about 200 to 300,000 people. So talukas themselves are comparable to districts in many other countries. And even at the taluka level, there is a wide disparity of health outcomes and health indicators. And several colleagues from the Indian Institute of Management in Bangalore and various other institutes have looked at health services in India and Karnataka, and a contribution of management exists to this disparity. So they have attributed at least some component of this performance of health services to management of these talukas and districts. So one of the recent publications called it a systemic failure, right? So if you come back to what it is to be a health manager of one of these talukas or districts in Karnataka, we are talking of a fairly dynamic environment. India is a country that is experiencing a lot of economic growth. So a lot of resources are coming in to improve health services at the district level. There is a reform called as the National Rural Health Mission, which is pumping a lot of money to the districts and taluka level. But there's not yet enough capacity to make use of this money such that it improves the healthcare services in these government primary health centers and hospitals, etc. And in addition to that is the fact that most of these health managers have been for decades in clinical specialties. For example, being a district health manager in Tumkur, the district I studied, could mean that you have been for 3 decades an ENT surgeon, or you have been an orthopedician in charge of large hospitals and departments of orthopedics. And in the 4th decade of your service, you might be posted as a district health officer in charge of providing and coordinating services of a large Indian district. So there's also a huge private sector in India now, and private sector care is increasingly being perceived, true or not is another question, but it's being perceived as being good quality, and as if the government services is then for the poor. If you don't have money, then you go to the government. If you're able to purchase good care and you know where to go, then you go to the private. So there is a lot of frustration that people in public services deal with. So they're dealing with a service that is not very supportive of them. They are themselves not enabled and capacitated to manage these services, and they are having an increasing competition from the private sector. In addition is this focus by researchers like us in the public health community who believe that public services ought to perform, and it ought to be of good quality, and it ought to be managed. So in the middle of all this again is this Indian health manager who is not perhaps in the best place to deliver all what the policies promise to the people, or on the other hand what the people demand. So if we say that, you know, with better health, if in fact our goal is to achieve better health status through these health managers and health workers, then I guess what we imagine is that we try to improve the health services. One of the ways of achieving better health status is to improve health services, and that in turn boils down usually to the people utilizing our services, what the government provides, and that's where good management comes. So ideally, a well-managed district is able to ensure that its services are of good quality and the people are utilizing these services, and this management in turn comes from performance. So one imagines that if there is a district that is well managed, then the health managers in such a district ought to be performing their duties and responsibilities well. They ought to possibly know what to do. And this boils down to capacity. So do these managers then have the capacity to perform? And that comes down to, do they have the skills? Do they know? And finally, the knowledge. So usually, if you look at human resource management programs in public health, by many of the agencies or development agencies or even country policies, they focus on this sort of an injection of knowledge, and they hope that we have these training programs which will somehow inject knowledge, and then somehow that chain will happen like this and result in better health status. But is it really so straightforward that everything boils down, that all action on ground is determined purely by knowledge that is lacking in managers? So I think this metaphor of transformation from a pupa to an emerging butterfly is what one recalls how human resource management interventions are designed. At least they are designed as if these people are pupas who need somehow the right kind of an evolution to emerge as a butterfly, and they hope that training programs are going to cause these pupas to emerge out as butterflies. But well, for a very long time, we know that this does not happen. We know that injection of knowledge is not going to result in transformation of people or organizations. This one is a very, at least it's world famous within the evaluation community at least. This is the Kirkpatrick framework of training evaluation. Some of you may or may not be familiar with it. Basically, it explains, it was already in the 50s that one Donald Kirkpatrick put forward this in his own PhD thesis on human resource management. And it explains how if you have a training program or a capacity building program, as sometimes it's conflated with, you start with participants' response to the training program, and already there will be a dropout here, and then even those participants who respond positively may or may not end up improving their knowledge in response to your training program. And even among those whose knowledge improves, will it automatically then be applied in their workplace? And even if it is applied in their workplace, will that result in an impact in the organization? So the idea of this framework is to already state to people that training programs cannot function as injections of knowledge. So there are a lot of factors involved at the individual level, at the workplace level, at the larger organizational level that determines how training programs work or do not work. It basically tells us about how capacity to perform may not automatically result in the performance itself because of various factors. Possibly we put a large circle and say environment, but this could be anywhere from the individual person's environment to the workplace and the larger district and society in which they are. And this is also quite well established by this framework by Potter and Brough, who did field work in several Indian states based on development agency related work on capacity building. And they talk about how change in organizations is not possible to, what I mean is, technical level change, things like changing checklists for supervision, or things like changing ward, a task list in a ward, which are smaller types of changes, are easy to achieve because they depend on simple tools like a checklist, and these can be achieved by training programs. Whereas the kind of change that we expect in public services, if we want entire services to shift from one level of performance to another, the kind of change we're talking about is much more at the socio-cultural level. So this is change where we are hoping people will change the way in which they work. People will make changes in their behavior and in the way they approach things. So if we say, for example, that a district health manager in India, or anywhere else for that matter, will now take a new approach towards, say, equity, or he will now use new resources that is coming in from programs in a way that it benefits more people, that he will apply new skills. These are sort of behavioral changes which cannot be achieved as if they are mere technical skills which can be achieved through training programs. So with this background, for a moment I would go back and say, how did this journey of looking at capacity and performance begin for me? And I think it began with, this is in the photo is Dr. Devadasan, who is a member of the jury as well as my director at the Institute of Public Health. He has been involved with, he as well as our institute has been involved actually with a technical a cooperation with the Institute of Tropical Medicine in Antwerp, where the idea has been to try and put organizations such as us in the lower and middle income countries in the driver's seat. We try and identify priorities. Where are the priority interventions for public health as perceived by local actors? Where does it have to be? And one of the first things that IPH and Deva's initial Delphi study showed is that districts in India and districts in Karnataka is the place where all the action is. What I mean by that is that districts are crucial to realizing this, whatever it may be, universal health coverage, better health care. Districts is where a lot of change has to happen, because a lot of change is happening at the level of policies centrally, but at district and sub-district level, a lot of work needs to be done. So with that, and this interesting initiative called Emerging Voices, in which I was a part of, my initial curiosity on what is the important question with respect to changing and improving public services began. And an opportunity came in the form of this training program called, led by a consortium in Karnataka called Swasthya Karnataka. In my language it stands for Healthy Karnataka. Several organizations were coming together in Tumkur district to try and see whether they can improve capacity of health managers in this district through a blended training program, about which I will soon talk about. So this was the district in question. It's Tumkur, and the district in India is already quite large. Like I mentioned, Tumkur has about 3 million population, and it's 80% rural. About 20% of Tumkur's people live in cities. And it has 10 talukas, which are these sub-districts that you see in the map. And the idea of this capacity building program in Tumkur, which I studied for my dissertation, was to involve these health managers. There were about 61 health managers in Tumkur, both at district and taluka level, and they were provided with contact classes, and they were provided with assignments and mentoring. So mentoring means that people who are giving the classes on management of, and these classes were on various topics related to management of health services at district and taluka. And these people visited the participants at their workplace, trying to help them apply what they learned in the classroom. So the idea was that participants are more likely to apply their skills, and the capacity is likely to result in performance if indeed they are mentored to do so. And with this, there was also a smaller program involving the primary health center medical officers and the local government representatives. So the idea was to also sensitize them to these improvements and changes that they are likely to see. So this was basically the intervention that provided me an opportunity to try and unpack and understand what capacity and performance and the bigger circle of environment means in an Indian district. So that was my question. So the dissertation started with the question of how do capacity building programs such as this one result in change, in organizational change, in improved performance. And of course, initially I started off with trying to find methods that will allow me to control this context, to try and allow to neutralize the effect of context in the different talukas. And over time, I think where I ended up with is to try and realize that the variation we see in society, which we call context, I guess is a part that we have to embrace and we have to work with it. So there's never going to be in the kind of how kind of questions or why does change occur kind of questions, a possibility of neutralizing the effect of context through experimental methods. So I settled for this method called as realist evaluation. I think it's not clearly visible, the top part. It's a methodological approach which basically begins with a very simple question of why does change or why do things happen for some in some places and does not happen in other places. And this is a very common phenomenon for most of us in public health. We design interventions, we design disease control programs, and we see that they work in some places and they don't work in others. And the most important question that realist evaluation starts with is to say why. Why is it? So if there is an initial situation, then any action such as the intervention in Tumkur tries to change this initial situation to a different one, which we believe is better. And usually we try to take into account a particular context in which this can occur, because it does not occur everywhere. And so realist evaluation basically tries to say that the reason why in some instances we are able to realize our outcome is because of underlying mechanisms. So there must be something in people and in societies that causes these kind of interventions to work in some places and not in others. So these mechanisms basically get triggered in relation to a particular context. So this sort of pattern of occurrences of context, mechanisms and outcomes is then what the evaluator tries to chase and tries to unpack and understand in this exercise of realist evaluation. So that's basically what I did. If you imagine that this is Tumkur, and if you imagine that there are all these talukas in Tumkur, which are each self-contained management teams of people. There are health managers working at all of these talukas. And then there is an intervention, such as the one I described before. It's likely to work very differently in these talukas. So through the evaluation, I try to understand what is it within this taluka that makes the intervention work in a particular way. Could it be the environment in the workplace? Could it be the dynamics between the team members in this taluka? What is the organizational culture? Does it promote teamwork? Does it promote a particular kind of leadership or not? So these become very important to explain why things work in some talukas and don't work in others. And of course, remembering that larger environmental factors like the state health policy and the state's priorities and how that influences agenda setting at the district and taluka level also matter. So this was the study design. I started with what is called as a program theory, which is basically a statement of why the intervention is likely to work in Tumkur. And that can be then used as a hypothesis for one to design data collection, analysis, and synthesis. And this happens in 3 cycles. In the first cycle, I wrote down the hypothesis of why this intervention is likely to work. And then I went about collecting details of why, what are the hindering and facilitating factors that may allow this intervention to work or not. And finally, through a selection of particular talukas where different patterns of outcomes and contexts occurred, I tried to understand and describe why is it that there is this variation across the talukas. What is it about these talukas that causes them to respond in a particular way to interventions? And the idea of doing this is to finally arrive at what we call as a theory of how Tumkur-like districts will respond to interventions such as the one that we studied. So this and the next 2 slides are statements, actually hypothetical statements of why this intervention was expected to work. So this was also an output of analysis of various interviews and secondary data and transcripts. So this kind of statements allow the evaluator to design data collection tools and then look for this kind of change. So the first one, the first part of the program theory was about classes, these training classes. And we said contact classes could work through commitment and efficacy of health managers who bear an intention to make positive change. So I think what I was trying to say is that it's not enough that interventions such as this one set an agenda of change in a district. What about the manager's intention? So these are not passive recipients of knowledge or skills. These are people who are making decisions on a day-to-day basis. Do they intend for this kind of change or not? And we said this is very central. And what is also very central to this change process is the local team environment within which they work. So it's not good enough that they attend world-class trainings, but what is the kind of environment they go back to and where they are supposed to practice with their skills. And how does this align the change agenda introduced by the intervention? How does it align with the local change processes by the local government and various other actors at the taluka and district level? The second part of the program theory was about mentoring, what the intervention called mentoring, where participants were visited by the people. It was likely it was hoped by the intervention designers that this mentoring is more likely to result in change because the participants, if they are visited by people, will apply these skills. So we said that it may be so wherever there is no hindrance or there is an alignment to such moves from the community or from above and below. And the last part of the program theory was about the ability to negotiate with various actors and also claim decision spaces because a review of literature as well as interviews with various actors showed that it's fine if policies say that managers, things are decentralized now and everybody at district and taluka level can take decisions. There may be these kind of policies on paper, but what matters is how people on ground perceive these decision spaces. Do they claim it or do they say, well, it's not really my decision, this has to come from above. So all of these we said are important in order for the change process to occur in Tumkur. So with this we went back, so that was the program theory, which in this case was not already a priori stated by the intervention, so which was the reason that why we had to go through the data and elicit from the actors what the theory of change is likely to be. So then we went to the contextual factors. What is it that hinders or facilitates change in an in a district in Karnataka? In this case, we found that participants of the program, their perceptions were well aligned with the change agenda of the intervention designers. This was through a survey, and we also found that they were receptive to technical guidance. They were open to involving what we call lower levels, which means that people from the local government, village level health committees, etc. So on a survey we found that health managers overwhelmingly said yes, this is okay. But a survey can only achieve so much. Survey tells us in averages and in numbers what percentages and proportions of people are willing or not willing. When we later interviewed people in many of the talukas, we found that it's not automatic. For example, there is this theme that emerged on nature of teams. So there is this large program called the National Rural Health Mission in India, which is in the last 10 years has been in place, which is providing a lot of new resources to the district and taluka levels, hoping for change. And one of the strategies was to appoint block program managers. So these are young management graduates who are sort of para-dropped into teams led by very senior clinical specialists, the district health managers that I mentioned earlier. So we said in whichever teams, this very senior doctor is able to work with a young management graduate who has just come out of management school now, wherever there is that ability to work together, then there may be a change indeed. But in most places, there was a hindrance for these people to work as equal partners of a team to manage services at the taluka level. And in a service that is fairly bureaucratic, that is giving a lot of importance to who said what. Did the order come from above or did it come from a colleague? So in this kind of a very straight-jacketed bureaucratic service, we found that how people look at giving away responsibilities to lower levels, etc., is a very important thing. So this is just one verbatim, but various people showed a mistrust of things happening at another level. In this case, this was a district level manager who said, what is the use of putting my time into the action plan if they will anyway change it at the state level? So people did not believe that there is really a decentralization happening. So they said this is just like before, there's a lot of words coming in the policy which is not in practice. And they said things as usual, I will not put too much efforts into health plans. And this is 10 years after the National Rural Health Mission promised decentralization. And the decision spaces, even if they were available in paper, were not perceived in practice by most people. We measured perceived decision spaces of health managers in various talukas of Tumkur, and most of them, in spite 10 years after the National Rural Health Mission's promise of decentralized local governments, they did not perceive that they have the decision space and capability to plan and implement their own initiatives. So with this we came back. These were all the contextual factors that we said allowed or hindered change. And we said, let's look at some cases of change across the talukas of Tumkur. So we identified case studies based on a diversity of context and outcome co-occurrences in the various talukas of Tumkur. And based on that, we reformulated the initial theory with which we started. And the case selection was based on looking at committed and mentored teams with low to moderate intention to make change, because intention to make change seemed to be very important and central, to poorly resourced teams. So talukas which are not very well resourced, how did the teams compare with respect to their intention for change? So if you go back to Tumkur, one of the so-called committed teams was Gubbi, where the first one it's not very clear, but the second one, if you see, more resources mean more opportunities to make change. If they slowly give more and more power to us at taluka level, we can make many improvements. Right now, very little is possible at taluka level. But there was in Gubbi, this is just one verbatim which represents the theme in Gubbi of high commitment and an openness to change. So in Gubbi, people aligned with the agenda of change presented by the intervention. Whereas in Chiksi and Halli, for short, another taluka, very poorly resourced, very relatively remote, and people were quite frustrated. So here they said, what action plan are you talking about? What decentralization? I sent so many requirements for staff and proposals for improvement. Only thing I got is more work, less staff, and zero solutions. On one hand, I have to answer the local government members' complaints, and on the other hand, I have to just keep implementing plans and schemes coming from above. Nothing can be done without more staff. So a verbatim which represents a frustrated manager who feels let down by the reform process. So these we found are very crucial to realize change, how the managers perceive the process of decentralization as well as such interventions. But it was not always the same. In Sira, which is comparable to CN Haldi in being poorly resourced, not relatively remote, and not very well to do, there was a feeling, there was this negativity, but there was a feeling of wanting to do something, somehow, he said. We felt that we have to do it. So many mothers were just being referred to Tumkur. The delivery load is high, and for several months we had only one obstetrician, but somehow we managed. I know the pressure is at the district, how the pressure is at the district hospital. So having cesarean facility at Sira decreases the burden at the district hospital. It's not easy, but somehow it's happening. So here a health manager who showed somehow an openness to battle whatever odds he feels. These are very important for change processes, that people identify or people are unhappy with how things are and say that whatever skills and knowledge etc. comes, I make use of these things to create this change. So with this we refine the program theory to state that committed health management teams could utilize new opportunities for organizational improvement presented by decentralizing health systems wherever their change agenda aligns with the expectations of the higher levels of bureaucracy. Now this is not a general law that applies anywhere. So this we feel is a sort of a middle range theory that applies in fairly bureaucratic health services which are undergoing decentralization now. So in these kind of instances, we feel that this alignment with expectations of higher levels is very crucial to realizing change. And on the other hand, tapping commitment for change it's not enough that people are committed. If they are in fact in poorly resourced talukas, in spite of their improved management capacities and intentions, they could get frustrated due to lack of facilitating action from above. And this is very important for interventions on capacity building to deal with. How do they deal with these frustrations of managers, even if they are committed and seek change? So to sort of summarize based on this refining of theory, what did I learn? I think the main lesson learned with respect to organizational change is that in very well structured bureaucracies like the one we have in Karnataka, change cannot be drastically achieved by external interventions. The kind of change that this intervention defined of seeking to shift practices of entire organizations from what it is to a drastically new level may not be achievable through training programs like the ones we designed. So change in this kind of scenarios will have to piggyback on managers who identify opportunities and alignments within their own bureaucracy. And second thing is that it's very important for the change process to function on structural changes in the way the health service in Karnataka is made. The mistrust of higher levels, the decentralization that is not actually being realized, all of these are very crucial, but somehow the reforms process tends to overlook it and look for technical solutions when in fact the foundations are still weak. In terms of methods, the application of insights from organizational and social sciences was very crucial. Some of the things that I discovered, although not well mainstreamed in public health, are being talked about for decades in organizational sciences and literature in the other social sciences. And second thing, an important lesson which is of post hoc reconstruction of theories. So most interventions at least in India are designed without too much attention being paid as to why is this likely to work in this district, of making a priori before they implement very detailed reasoning of why my intervention is expected to work, and which is why I had to reconstruct the theory of this program afterwards. And finally, about using this kind of program theory based approaches to fine-tune implementation of interventions is a third lesson that I learned. Two limitations. One is this is a photo of course of Kekule, who who's supposed to have discovered the benzene structure through, because he already had it in his mind of the snake trying to bite its tail. So it recalls a bit also the limitation of a program theory approach. If you have, you tend to see what you think you will see. So the need to be as comprehensive as possible when the lens is being defined. For example, my own program theories did not look at the quality of teaching. So could the quality of teaching and pedagogical lenses improve and provide a better explanation of the change that I saw or did not see? It's possible. So that's one of the important limitations, I think, of this approach, which is how comprehensive can one be with respect to framing program theories and theories of change. And the second limitation is, of course, of complexity, which is that in a kind of scenario in districts where we work, it's very difficult to say we make this intervention and we realize that kind of change, and it happened because we did this. So this kind of questioning is also very difficult, which is why early on in the study I shifted from asking, does a training and mentoring program result in change, to why will such a program result in change in some places and not in others. With that, my last slide is on relevance of this work. This has been of importance not only to me but also to my institute, because the method itself and the larger school of method, the theory-driven inquiry methods, are very new in most of our country settings. And most interventions in public health back home do not invest enough in evaluation, do not invest enough in understanding why is it my program is working or not working. So I'm hoping that some of the insights will contribute to improving the field of evaluation locally. I have already had the opportunity to start teaching and make case studies out of the work that I presented here. There is a WHO Alliance funded Keystone initiative to train health policy and systems researchers in India, in which realist evaluation is now included as one of the methods, one of the approaches. And I'm hoping, we have already started engaging with the human resource strategy in Karnataka, which continues to rely on industrial scale training programs, large batches and batches of training funded by the World Bank projects, funded by various development partners, where there is a huge investment in large scale training. So I'm hoping that some of the insights will inform better design and delivery of these training programs, and will also make the expected outcome of such trainings more realistic than trying to achieve for organizational change through these programs. I end with this very nice quotation I found in this book, A Realist Theory of Science, which by Roy Bhaskar, who is the pioneer of critical realism, based on which the realist evaluation method comes. On tendencies may be possessed unexercised, exercised unrealized, and realized unperceived by men. They may also be transformed. Thank you.
Thank you very much. Now it's time for questions. We will begin by Professor Urtig.
Thank you. Thank you very much, Prashant, for a very good presentation, and it has been a pleasure to follow your work. First, when I was asked to be in a Belgian jury, it looked a bit cumbersome because you have to, there's a private defense and there is a public defense, but actually I think it's a point because you come to follow a process, and I really appreciate that. And I've seen how the two versions, how it really has evolved. And I think it's really a pleasure to read your thesis. And you're also a poet. I've come to learn reading the second, the final version. I think I have like two broad questions. The first is around your final program theory. Can you show it there? Yes. about CMOs, and we talk about CMOs, and then suddenly there is a program theory like this. Can you kind of tease out here the context, the mechanism, and the outcome from?
Yeah. The central to the realist evaluation method, like you pointed out, is this interplay between context, mechanism, and outcome. And I think in the realist sense, if theories are framed in the realist sense, they also should reflect then this relationship between C, M, and O. In this, I would situate commitment as the mechanism through which management teams or managers need to realize their positive outcome. And the context here is the alignment of the change agenda with the bureaucracy. Because like I explained, this is not a universal law. It's not that committed managers everywhere need to find such alignments. But what my work in Tumkur shows is that the alignment with higher levels of bureaucracy seems to be very central for committed managers to realize change. So if change is kept as the outcome, then commitment is the mechanism, and the alignment with the agenda of higher levels of the bureaucracy is the context. I would explain it like that.
And the white in the middle, what do you do with that?
Well, I mean, that I would say is the way they interact. How does a committed manager realize his commitment for change? He realizes it through utilizing the new opportunities that come through the intervention or through any reform process in translating his commitment into the outcome.
So would that be about this claiming decision space?
It could be about claiming decision spaces. It could be also about being in a team with a very young manager, trying to neutralize his distance, for example. That's another thing we found, where if the in an Indian district, being at the head, a very senior clinical specialist, and being a young management graduate being dropped in, it works only if this clinical specialist says, okay, here is, instead of saying, okay, this guy doesn't know anything, he says, okay, here's how I ensure and train and mentor him to do something for this place.
So it seems like some of that is also part of like the mechanism.
Yeah. Yeah. I mean, the way I see mechanism is that it has to be something that is universal within anybody. So I would situate it as commitment need not be what I say positive or negative. It could be any nature of commitment to one's organization. So that I would say is a mechanism.
And then if we go to the two main cases that you have, which is Gubi and Sage Halley, is it the commitment that is
different?
That is the main difference.
So when I did the analysis, what I did rather than to just pick on commitment is to put that large table and say I pick rather co-occurrences of situations. I rather went for situations. So in Gubi was a committed team with a positive intention to make change, and they benefited from the intervention. So I said, okay, this is one kind of a scenario. Whereas in C and Halley is a committed team, but not having an intention to, how did I say committed? Because the measures of commitment were relatively better.
Yeah, because it looks from the text that they were also committed somehow.
Yes, they were. But rather the interviews showed frustration. So it showed passionate managers who say there is just nothing happening, there's no use of these kind of programs. So that's the one that inspired the second part of the theory, which says that if there is not somehow favoring contextual factors for these committed managers to be in situations where they can realize their commitment, then their commitment is not enough. That's maybe like I said, some of it is unfortunately also a framing exercise, because it's also the way one frames these sentences, which also is very crucial.
understand it's tricky. But it seems like the frustration stands out in CH Halley.
Yes.
Yeah.
Yeah.
But is that how different is really the context, and how different is the frustration that is created within? Because they are in the same district.
They are in the same district, no doubt, but like I said, one of the indicators we took into account is also the development index, the socioeconomic development index. And CN Halley stands out as being in a very poor setting. So this is something that's not under the control of health services. So these are managers then, committed managers, posted in remote areas. For example, CN Halley is a taluka where there is zero private sector, and it's a remote taluka. So some of the contribution to the frustration could also be because of being posted in such places.
And that's not coming that kind of minimum level
in
your
the formulation of
yeah.
I mean, the way I see it is that I don't know to what extent I've succeeded in that exercise. Is I've tried to go a bit away from Tumkur and try to lose the granularity of the context while framing these refined theories. But in losing the granularity, the trade-off is these kind of aspects.
Okay, so that was around this. And then you, throughout your thesis, you talk about how to move on, and or the importance of moving on. And in your afterword, which I think is very nice, you have a very, I think, again poetic last sentence.
I see.
Because you talk about catching fish and how wide the net has to be, or the trade-off there. And I think I read the last sentence because it says, at some point, the need for wider nets for improve the catch of fish is compromised by its unwieldiness. So if you move on now and you want to catch fish, how are you going to prepare the net?
I think in some sense I've become a bit skeptical about catches of fish. I think, like I mentioned in the afterword, the more I read, some of the theories, for example, like self-efficacy, which is one of the theories also that I talked about, it emerges from fMRI studies. So they have tried to understand self-efficacy with respect to differences in particular regions of the brain. So these are neurobiology and that kind of sciences. And on the other hand is sciences related to emancipation and moving societies towards better things, and then there is this whole discourse of structure, agency, and these kind of things. So I don't know if usually whatever color a social scientist might, I mean by color I mean by whatever the discipline from which a social scientist might be, I don't know whether one person can navigate that breadth of sciences. So I think so that's the skepticism part. But what the positive lesson I take away is what I read in the literature on complexity on good enough solutions. So there are not going to be sort of magic bullets to transform organizations anyway, and that's how the private sector works in fact. So what do we need to get through this situation to a small incremental change and good enough solutions, which may be quick and dirty sometimes, but not necessarily universal sort of things.
And would you also go for a more quick and dirty design of research in the future, or?
No,
no.
Well, I would say the quick and dirty approaches, I would say more for things that we do not know well about. If I would look at capacity building and organizations like we have in Karnataka, I would possibly decrease the kind of change one can achieve in 3 years. I would probably suggest programs not to try and strive for the kind of change that we did, or rather work at looking at structures. For example, the simple low-hanging fruit would be, why have clinical specialists, after decades of being in clinical specialties, be put as managers at the district or taluka level? There is a structural change one can then talk about for this. So I would go a bit for some structural changes and incremental improvements, programs that target small improvements.
Would that have a consequence as well for, let's say that you go for other rounds of realist evaluation in selecting outcomes? Would it have a...
Sorry, can I...
If you go for other rounds of realist evaluation, and you would to select which outcomes to look for.
Yes, I would then possibly look for outcomes that are more proximal to the training or capacity building processes. For example, what I spoke about earlier, the pedagogy is something that I have not touched upon at all. The way the intervention itself was delivered was not evaluated. So some of those outcomes I would take into consideration if I would revisit or if I would go to different cases.
Okay, thank you.
Thank you very much, and thank you for being present today. Professor Kegels?
You don't give priority to okay. The general sense of my question would be, if you were to start this intervention all over again, how differently would you do it? That is a very broad question, I realize. So let's maybe track back a little bit and start from how it worked. So the initial intervention, if I understand correctly, was a result of an investigation through a Delphi process and so forth of what was lacking in the then present situation, coming to the conclusion that something needs to be changed at district level. Probably, I imagine it had something to do with the fact that the people who are in charge of these districts and maybe also the leaders were actually not prepared for that kind of job. And the lack of preparedness was located by those who were doing this initial investigation in knowledge, competence, and skills. Hence, classes, mentoring, etc. To what extent would you say now, maybe let's limit the question at that, what was wrong with that initial assessment?
Firstly, I don't think it was wrong. But I think I would say that we jumped a step from that initial assessment to then designing a program to actually, like the injection metaphor is for me interesting. So we jumped from that initial assessment of saying there are knowledge, skill, and competency gaps or capacity gaps to be brought to then let's inject it into the system and then change. So I think what I would then think of is why will a district like Tumkur, why will managers in such a district seek change? So I would, why will they align with the inputs that an intervention is giving? So I would possibly have gone in for a series of discussions which involved multiple levels of the system, right from state, district, and PSC. Possibly more discussions with them in designing this intervention. That's one way of looking at it. Saying that better informed information about the context could have given us clarity beforehand about the intervention. But that said, I think there are some problems in the way health services are structured itself, like I said earlier. So the way who becomes a health manager and how supported does he or she feel, are very important in Karnataka, and that has not been taken into account, I think, by the policymakers. So I would go for a two-pronged approach. I would work with policymakers to try and have better postings and transfers of district health managers, and on the other hand, a more context-informed program through more discussions with multiple levels. I don't know whether.
But still acting or trying to act on skills, competencies, capacity.
Yeah, because I mean, in the current system, there is that gap. Now, why is it there? Is the question. And one of the things the Delphi said, it exists because these people are not trained in knowledge and skills of public health management. For example, conducting a situation analysis of a district.
Well, I just happened to have been asked to review a publication about an experiment that is going on in the Canadian province of Saskatchewan. It's not a very big one, it's smaller than Tunkor district. But of course the health services are a lot more developed and bigger, etc. But what they try to do there is to generalize and impose what they call a version of lean management. And the way they do it is by training people for leadership in this approach, which I think might be said to resemble something like indoctrination rather than capacity building. It is turning people into enthusiasts for change. Apparently it does not work always. It works sometimes, but it works. But I think that the basic difference with what the program that you have studied here would be is that it positively, it doesn't use the word indoctrination, but it positively says we want to make people feel comfortable with leading for change. This distinction that I see now between training as capacity building and training as indoctrination. Do you think this might have something useful in it for what you are doing here?
No, certainly. I mean, that's the way we conceive change. If we conceive change as being in the socio-cultural domain, in how people change the goals for their organizations, for example, that's the sort of change I think at least the implementation designers were desiring. That the Guppy health manager would say, I cannot handle this kind of maternal mortality. I need to do something about it, and I will do what it takes. So for that kind of goal setting and change to happen at management levels, it's insufficient to have training programs. It requires, I know it's insufficient. I don't know what it requires in Tumkur, but I could imagine that programs like this, which tend to make people dream bigger or have larger goals for public services, change the way they look at accountability for public services, for example. That I would imagine is the kind of capacity building that would be required.
That's the last part of my question. In what you have gone through a lot of literature and all that. Have you come across ways that have you come across literature that suggests how to do this second thing? You have used also how do they call Potter and Brow. I agree. I have read that paper also. I agree. It's very, very well written. It's exact what they say. But how do you do the difficult thing there?
I don't know. I mean, I think the key question for me is then how do I get district managers to ask this question of saying, how do we? I think that would be the whatever it is that we have to do, and because apparently they have the sanction, they have the spaces which they have to then claim for what they have to do. One of the things I was myself coming across, it's still too early to say that this is the answer to your question, is this thing of reflective practice that I saw from many South African settings, where of long periods of discussions on how people work. It's been done with GPs, it's been done with PhD doctors, with family practitioners, of long periods of reflection, and when getting people to talk about what is it that I'm doing and why am I failing. But these are individual level engagements, and somehow the context out there, be it funding agencies, be it institutes, they want slightly industrial scale things. So achieving that balance, I think, is
You will do very much wrong probably with the industrial action. It clearly never is enough. Okay, thank you.
Thank you. Is Professor Devadasan with us?
Thank you very much. So now the promoters, Bart Kriel and Jean-Marc.
Thank you very much, Prashant, for this very nice and very clear presentation. In principle, it's not the custom that I as co-promoter would raise any questions, but I nevertheless will, if you allow me, Prashant. One of the issues we have been discussing now and in the past with you and also your colleagues at IPH is the possibility to train health workers, health managers, health professionals in the private sector. As you pointed out in your introduction, well, the private sector, private healthcare delivery sector in India is very large. It's responsible for a large part of the provision of healthcare. But your course is focusing on people in the public sector, and rightly so. I don't think we can disagree with this priority. Now, my question would be, or my invitation for you to reflect would be on the following. Do you think there is a case to be made to include private practitioners who are working in the same talukas, where these health centers are, where these managers are? Is there a case to integrate them in the training? If not, why not? And let's assume you say there is a case. How would this affect the design of your training, the program of your training? Are there things a priori that you would do differently?
No, there is certainly a case to be made because private sector, like you say, they say it varies from one place to another, but some places nearly 80% of the outpatient care in India is provided by the private sector. That said, inpatient services and vaccination and preventive health services, health promotion is again dominated by the public sector. The case is, there is a case to be made, but I feel it's still early days, I think, because at the district level, even in this intervention, health officers and management teams themselves did not count in private sector actors as being part of the health system. So that also needs to happen before we jump again into training them together. I think larger discussion is needed across these districts on what is the role of private sector and how does one engage with them. Also in a non-confrontational way. Right now, the only engagement between public and private sector is on enforcing laws on various laws. So that's not the only way of engaging. So I think that dialogue has to start before this, but yeah, it has to happen.
Jean-Marc?
Well, thank you very much for indeed this very nice intervention, as it has already been said, and it's indeed you have really a very strong capacity to sort of communicate message that are not so easy to communicate. Maybe I also allow myself for one question, but very broad questions. By listening all the responses that you have given today, and again by reading your thesis, I wonder whether you shouldn't change the title of your thesis. It's called about realistic evaluation of an intervention. But wouldn't it be more correct to say that actually you are doing an evaluation of a system, and it's actually the evaluation of the systems that really allow the proper changes rather than the evaluation of the intervention?
But, yeah, I agree, but one is, of course, how I started this is to evaluate the intervention. But I think in course of time, as I evolved in terms of the question, I ended up looking much more at organizational change rather than only limiting to the intervention. but it's true. Eventually, where I've ended up is with the system, but I started with intervention.
Thank you. There is room for some questions among the audience. Other people? Yes, please.
Yeah, because my background is education science. So in your presentation, you also said your PhD project didn't really look at the education from the education angle, which means you didn't think the quality of the training, whether it has significant impact somehow related to the outcome you wish, which is change.
No, there's no doubt that the quality of training
So I listened to your presentation, and I think it really gave me some, make me reflect on certain issues. Here, we say, as you said at the beginning, the starting point is you have a kind of evaluation on the situation. You realize that you said the district manager lack of skills, knowledge, therefore they lack of certain capacity to do certain things. But I see that you have never really mentioned attitude. But later in the theory you mentioned people really need to be motivated to do it. So my question is, as related to this question, if you redesign your future training, whether you will really look at the attitude aspect. As you say, if you wish people to make change, but in a training, maybe you should design a certain intervention to create such kind of emotional needs.
Yeah, I think I did not put it in that chain, but attitude, the intervention designers called it a can-do attitude. Actually, that was the beginning for me to try and connect these theories, because the intervention was designed saying that we want to bring about a can-do attitude among the people, and that seemed to also guide this mentoring process. The mentoring included trying to say, come on, let's try and do things. But like I said earlier, this change process is extremely difficult to standardize, for example, across different mentors or different districts, to standardize an input that targets attitudinal change. And second is that some of these people are fairly senior people. These are also not students, for example, where perhaps attitudinal change is easy. I don't know actually if it is easy at a younger age. But I think that is very important. Motivation and commitment captures it in one way. But what also captures it is what I said is people's own unhappiness with how things are. This is also something that through long discussions with Guy and Bruno, I have been seeing that it's applied elsewhere also. It's very important for managers to already feel that things are not going well and I need to do something about it. So that kind of an attitude, if you speak of it like that, then that helps. I don't know how to create that. I don't think I have been able to find that out. But interventions can piggyback on that kind of attitude. That's how far I got.
Thank you. Other questions? I guess that there would be more questions. It was not true. It doesn't matter. Thank you. Now the jury will deliberate, and we will be back in a few minutes. Thank you. Of the three questions listened to me. On page 151 of your thesis, you write, the need to link intervention design and implementer assumptions with a larger theory is crucial, else the evaluation runs the risk of evaluating the theory rather than the intervention. Would you elaborate on this, please?
Yeah, this is because I think I have also been reading a lot of theory-driven, especially theory of change has become a popular approach. So what I meant there is that sometimes the exercise of choosing a theory that matches the implementation and the context is very crucial. Otherwise, there are various theories out there we can pick on to explain any kind of intervention. So for the evaluator then to be very critical and choose a theory that is really being also used in by the intervention designers is important. Because
but I will give you a brief translation after. Vu le décret du 31 mars 2004 définissant l'enseignement supérieur, favorisant son intégration dans l'espace européen de l'enseignement supérieur et refinançant les universités, nous, présidents, secrétaires et membres du jury chargé de conférer les grades académiques concernés, déclarons que Prashant Nugeali Srinivas, né en Inde, a obtenu en l'année académique 2014-2015 le grade académique de docteur en sciences de la santé publique. This means that you fulfill all the requirements for getting the PhD. Congratulations. L'intitulé de la thèse soutenue est Capacity Building and Performance in Local Health Systems, a realist evaluation of local health systems strengthening intervention in Tumkur, India. En foi de quoi, nous lui avons délivré le présent diplôme, attestant en même temps que les prescriptions légales relatives aux conditions d'accès au programme, à la durée des études et à la publicité de l'examen ont été observées, and congratulations. I think Bartri has a few words, but during the talk, could I ask you to sign there and there?
Dear Prashant, again, congratulations with your PhD degree. I think you had a very nice presentation. You did very well in your defense. Well done, and we are very proud of you. Now, you know, it is a little bit the custom that at the end of a public defense in a speech by one of the promoters, that we say a few words on the candidate himself. So bear with me, I'm going to try and briefly describe you a little bit. Prashant is a person with a great many layers that shape his being. Prashant is the son of two very nice people whom I had the pleasure and opportunity to meet a couple of times here in Belgium, but also in India. Prashant is the brother of a charming IT specialist who lived and worked during several months here in Mechelen at some point in her career. Prashant is the husband of Tanya, a strong and bright Indian health professional. And some of us here in the audience had the occasion to attend their marriage in Bangalore a couple of years ago. A nice event, a beautiful event that really balanced between Indian tradition, Hindu customs, and Western style. Prashant is also a researcher. He's a teacher. He's a passionate health activist. He's a blogger. He's a gifted photographer. He's a musician. Even Prashant, you still have to improve your guitar playing skills. You're not ready there for a PhD. Prashant is an environmental activist. He gives talks at bird festivals, I saw in a recent year. And now I also discovered together with you, Anna Karin, that, and you should have a look at the introduction of his thesis, that he is a poet. I like to imagine that, Prashant, you also found inspiration for your research writings in the beauty of the forest environment of the Bihar Hills in the north of Tamil Nadu, where you and Tanya are living when not being in Bangalore for work. It's a wonderful environment, with scope, I was told, to even see and catch a glimpse of wild tigers coming to drink from a water pool. This show must have been a magnificent source of inspiration. The PhD research of Prashant has been a special journey. It started 5 or so years ago with initial and, I must say, a bit worrisome plans to organize some sort of randomized controlled trial to test the effect of the Tumkur management course But as you have heard, in the course of events, it later switched to something very different, very much inspired by theory-driven inquiry and realist evaluation. It has always been a great pleasure to work with Prashant. And you should know that we learned as much from you as vice versa. Now and then it was, however, necessary to grab you by your collar and ask you to focus a little bit on the PhD and for the time being putting hold on the many, many other things you are doing. There are, of course, there are a number of people to be thanked. And I must say this thesis has really been an opportunity for many to interact. It has been teamwork. The list of people is long, but please allow me to just mention the most central ones. I first want to thank the PhD Commission and the jury members. I want to thank William. William is a very gentle chair, but he comes to the point when it is needed and firm when it is needed. Thank you, William, for that collaboration. Great thanks to my colleague, Guy, who is an erudite man and a great source of inspiration. Thank you. Thanks also to Deva. He's not here physically. Deva is an academic, but perhaps more than an academic, he's also a down-to-earth, pragmatic man. A bit different style than yours, but I think you are complementing each other very nicely. I also want to thank my good friend, Jean. Jean, thanks for the pleasant teamwork all over these last couple of years. Also, a word of thanks to Anna Karin, who came especially from Sweden for this defense. We are very honored and we hope that this is an opportunity to further strengthen our collaboration and institutional ties. A very, very special word for my ITM colleague Bruno Marchal, who has been a precious resource person in guiding us, you and me, in the methodological meanders of theory-driven evaluation and realist evaluation. And without him, this probably would have been a very different thesis. So thank you. I also want to compliment the Institute of Public Health, Bangalore, and its faculty. I'm biased, and I'm aware of the bias, but nevertheless, I think IPH is a great institution. IPH manages to come to a nice blend of research, training, and service delivery, and trying to carefully balancing these three things, and I believe that we at ITM can learn from you in that perspective. IPH is a young institution. It's less than 10 years young, but it's already a major player in the Indian public health scene. And I think, Prashant, that this PhD will further put IPH on that map, and you've alluded to it with the courses being organized in Delhi. Moreover, there are other PhDs to come. There are some of your colleagues that are going in the next couple of months also to obtain their degree. I'm thinking of Upendra and Shri, but also later, the next couple of years, Dorothy. You may not expect it, but also a word of thanks for my colleague Werner Soos. Werner Soos is actually the president and the principal member of the Antwerp-based IPHD SSA. The IPHD SSA, which is the Indian PhD Students Shelter Association. Werner, thank you very much for lodging and feeding and coaching all these Indian PhD students that come to Antwerp and then stay with you and, for a couple of weeks. Let me end with a cliché. Behind every strong PhD, there is a strong partner. In Prashant's case, there is Tanya. And Prashant actually refers to her in his PhD forward in a very unique way. And for the scientist in the audience, Bruno, Prashant actually added a previously unknown and yet unpublished romantic dimension to theory-driven evaluation and realist evaluation. When he writes about his wife, Prashant writes that if he had to isolate a mechanism, for this PhD outcome, he would situate it in his relationship with Tanya. Good. let me stop here. Prashant, congratulate you once again, and thank all the people that have come so well. Thank you very much.
Thank you very much for this, and thank you very much for to all of you, but also particularly to Bart for a very touching summary of these 5 years. It's been a wonderful journey, and there are a lot of people to thank. I will not make another list now. I will invite all of you to a short reception that we have planned, and I hope you will join in the discussion. Thank you.